First of all, we will talk about the left parasternal window. The left parasternal window is between the second and fourth intercostal space, left sternal edge. And if we look at this picture, this illustrates what we are talking about. This is the sternum, and this is the intercostal spaces, and this is the left parasternal window. This is the apical window, and this subcostal, this suprasternal, and left parasternal. The first view we'll get from the parasternal view is a parasternal long axis plane. And we have to put our patient his left side, and his left arm should be raised. The back of the bed or use pillows under left shoulder is not so mandatory or important, but the most important part is that the patient have to lie on his left side, and his left arm should be raised above his head. Then we will start from the fourth intercostal space, left sternal edge, which is here. Our marker or our transducer must be directed toward the right shoulder. This is how to start to get the view. But if anyone do those steps, he will get a parasternal view. Does this mean that this parasternal view is optimum view? No, because we will see that if we started in this fourth intercostal space with this direction, we will get non-optimum parasternal view. Non-optimum parasternal view. And here is the point, and here is the difference between a skilled operator and non-skilled operator or a beginner. What is the difference is that how to optimize your image. Everyone will get parasternal long axis view, but not everyone will get the best and optimized parasternal view, because with optimization of the parasternal view, we'll optimize our measurement of aorta, of LV linear dimensions, and of LVOT dimension of many dimensions. So it's very important to optimize our parasternal long axis view. And here is a note. We should remember that the patient respiration will affect the image. Expiration improve parasternal long axis view, and it may be necessary to have the patient perform a press hold at end expiration to optimize this view. And here is a very important point, is that we sometimes need to ask the patient to hold his breath. And when you ask the patient to hold his breath, the patient will automatically hold his breath in inspiration. For example, if I told you, excuse me, Dr. Amira, hold your breath, what will you do? You will do like this. So you took a deep breath and you stopped your breathing. This will get us a very bad image, because the patient hold his breath in deep inspiration, and holding breath in inspiration makes the lung fill with more air, and this more air filling will make more attenuation to ultrasound beams, because the air has very bad acoustic properties and most of the waves will be refracted and attenuated. So it's very important to explain to the patient how to hold his breath. I will explain, I always explain to the patient like this. Please, our patient, take a deep breath, then let it out, then stop breathing. So I instructed the patient that he will hold his breath at expiration. And every echo measure, we do it at holding breath at end expiration. Even TDI, tissue Doppler imaging, we make the measurement at end expiration. So what are the anatomical findings that we will see in this parasternal long axis? If we imagine that this is a transducer and this is the ultrasound beam sectors that is emitted from the transducer, we are looking at the heart. The most anterior chamber of the heart, as we know, is the right ventricle. So the ultrasound beam will first of all cut through the RV. Then there is the interventricular septum, then there is the left ventricle, and behind the left ventricle there is the left atrium. In between the left atrium and the left ventricle there is the mitral valve. So this is the parasternal long axis view that we will get if we put the transducer here. The optimum parasternal view, as I have wrote here on this slide, is that the LV apex must not be seen. If you see the apex, the LV apex in parasternal long axis view, you have a wrong view. You are having a wrong view. You have to optimize this view. And there is also another tip in optimized parasternal view is that the interventricular septum must be horizontal. And you will see this in the next slides. As you see, this is an example of parasternal long axis view. We see here the left atrium, then there is the mitral valve, then the blood flow to the left ventricle, then there is the LVOT and the aortic root and ascending aorta. While this is the interventricular septum and above it there is the RV, as we explained in the previous slide, that the most anterior chamber, which is the most proximal to the probe, is the right ventricle. So this is the right ventricle. And we should all memorize this slide because this is the anatomy of the parasternal long axis view. We see here the RV free wall, then the RV cavity, then there is the interventricular septum. To be more specific, there is the anteroseptal wall because the septum, as we will see, is divided into anteroseptal segments and infroseptal segments. And as if we see the aorta in the view, this is automatically the anteroseptal. Then we have the LV and the mitral valves. This is the anterior leaflet and this is the posterior leaflet. Then we have the posterior wall of the LV, which has a different name in some nomenclatures as known infrolateral wall. So the posterior wall is the same as the infrolateral wall. This is the pericardium, and there is small structure here in the atrioventricular groove, which is the coronary sinus. And then we have the descending thoracic aorta behind the left atrium. We also have two cusps of the aortic valve. The cusp which is near to the RV is called the right coronary cusp, and the cusp which is near the left atrium is the non-coronary cusp. The third cusp, which is the left coronary cusp, does not show in parasternal long axis view. Then there is the ascending aorta. Tips for better study. The view should begin at a higher depth to assess for the presence of pericardial or pleural effusion. So I will get my parasternal long axis view and I will start at high depths to show the posterior mediastinum. When I make this tip, I notice that there is two cavities filled with fluid. So one of them is pleural effusion and one of them is pericardial effusion. So how to differentiate between both of them? The clue here is that the descending thoracic aorta. When we look at the left atrium, behind the left atrium there is rounded structure, large rounded structure, which is called the descending thoracic aorta. If we notice that we have a fluid collection between the aorta and the left atrium or in front of the aorta, this is pericardial effusion. While if the collection is behind the descending aorta, it is pleural effusion. So if we see a collection here, we have to search for its relationship to the descending thoracic aorta. And let's see this example. This is parasternal long axis view. I increased the depth so that I reach it to the mediastinum. And we notice that there are two fluid-filled spaces here, one in front of the descending thoracic aorta and one behind the descending thoracic aorta. We even notice that there is gray soft tissue mass here, which is collapsed lung lobule. So this is 100% pleural effusion. As we explained, this space is in front of the descending thoracic aorta, so this pericardial effusion, and the other fluid-filled space is the pleural effusion. Second question is that what are the criteria for the optimum parasternal view? One, the interventricular septum should appear horizontal. Two, the apex must be out of the view. And we will see examples for this and how to overcome those problems. The first problem, if we have the apex in the view, if we put the probe in the fourth intercostal space and the marker towards the right shoulder, but we notice that there is apex in the view. This means that this transducer is more lateral. It's cutting not over the RV, it's cutting over the apex. And as we all know, the apex is the most lateral structure in the heart. So if we have apex in the view, we have to slide medial. By sliding the transducer slightly medial to exclude the apical wall segments. The second problem, if we have the septum oblique or vertical, and I will show you example for those problems. If we see the septum, intervertebral septum upright or vertical, this means that we are very close to the apex. And in parasternal view, we cut over the base of the heart, not the apex of the heart. We have the apex of the heart downward and the base upward. In parasternal window, we cut at the base. So if we notice that the septum is vertical, this means that we are very close to the apex. We have then move upward. So the solution to the first problem, if we have the apex, is sliding medially. And if we have vertical or oblique septum, we have to slide upward. Let's apply for those problems. If you look at the very low image, the lowest image in this slide, what do we notice here? We notice two problems. The first problem, we are seeing the apex. This is the apex. And we said that we should not see the apex at all in parasternal long axis view. And the second problem is that the septum is vertical. And the septum, as we show in the previous slides, must be horizontal, like this example up in the very up example, the uppermost example, the septum is transverse. So how to correct this wrong view to the optimum view? If you notice the two videos in between, we are moving up and medially. By moving up, the septum start to lie horizontal. The septum gradually become horizontal. And by moving medially, we exclude the apex. So this view is not optimum view. And if we try here to put an M mode over the LV cavity, we will get oblique cut. And we will overestimate the linear dimensions of the left ventricle. While this view is the best parasternal view because it has the two criteria for the optimum view. We don't see the apex and the septum is transverse. If we applied the M mode here for linear dimension of the LV, we will have perpendicular line cutting the septum and cutting the cavity. So we'll have the best measurement and we will not overestimate the measurements. So this wrong view, as we said before, we are seeing the apex and the septum is oblique or vertical. This is wrong, so wrong. And this is right view because we don't see the apex and the septum is more transverse.